Hello, everyone, and welcome to our chat tonight with myself and Flipper. And we are very grateful to have the wonderful Dr. Rose Stewart along tonight. Rose, can you hear us okay? And can you speak okay? And we hear you?
Yeah, I can hear you loud and clear. Hi, Mary. Hi, Pippa.
Yay!
Hi, everybody
Happy
else.
day.
Hello. This is my first diabetes chat. I'm very, very excited. It's yeah.
Is it
Us
your first
too.
time? Is it your first time listening in as well? I can.
No, I have listened. I've done listening and lurking lots of times in the past. But yeah, so it's my first time in real life speaking though.
Good job. What do you think of it?
It's very cool. It is very cool. I think, yeah, it's amazing. I was thinking about this earlier, just how much the sort of online community has changed, even over the last couple of years. Because I think when I first started working in diabetes, and I found things like the GB doc and the tweet chat that happened, the that
Yeah.
was that seemed like this whole brave new world of tech. And then now look at us, it's like, yeah, we've got our own radio show. It's completely mad.
I know it is kind of like a radio show.
It
Totally.
is. Well, I was trying to work out, is it more like a radio show, or is it more like, and I will be giving away my age for those of you who were teenagers in the 90s, do you remember three-way calling that you could do on the phone? You could dial other people in, and it cost
Yes.
like 70 quid a minute. We all got in massive trouble when the phone bills came.
I didn't have that, but then I was in the sticks in the south of Ireland, so maybe we didn't have that in. It might have been a
Yeah.
UK thing.
I spent
Mm.
many a long hour as a teenager racking up huge phone bills with that. But yeah,
Sitting in the
luckily,
hallway.
yeah,
Yeah.
not so much now that we've got the internet. But yeah, no, it's lovely to be here, and yeah, lovely to talk about this stuff.
Well, I'll introduce you to everybody in case they don't know you. I'm sure so many do. Dr. Rose Stewart is a multi-award winning consultant clinical psychologist working in North Wales. She is acting diabetes psychology lead for Wales and the chair of the UK Diabetes Psychology Network. She also writes guided self-help books for people living with diabetes, the Talking Type 1 range. She's a Diabetes UK clinical champion, works closely with JDRF UK and Action for Diabetes, and is a member, probably other things as well, and is a member of the Council of Healthcare Professionals and lectures and does so many things. But she uses a range of approaches and works with high risk client groups and has particular interests in like eating disorders and shame and compassion and empowerment for people with long-term conditions. And what I think is really key is working on creating psychologically informed care systems as well, like to bring it all together for a piece that was not included for so long. Welcome to the chat, Rose.
Thank you, Mary. Yeah, it's a very long and boring introduction. I think that's one that I wrote a long time ago. But yeah, I think it basically just goes to show that if you are a psychologist working into this field, you get dragged into every project going, which is very exciting. But yeah, it's very busy at the same time.
Yeah, how like because to try and talk about it in simpler English, I think it would have been here for an hour because there's so many different little elements of it. But yeah,
Yeah, I think, well, it's working in lots and lots of different teams. So I think my main day job is working in lovely sunny Wrexham, which is I guess famous now for Ryan Reynolds having bought our football team. We're
yes.
desperately trying to work out a way that we can get him to come to the diabetes centre. We'll have to get him to open something or something.
Let us all know if that happens.
So yeah, the day job is working there, and most of the work I do is with young people living with type 1, but I also work with adulty adults, which is what we officially call people over 25 as well.
Adulty adults. I'm
Adulty
writing that down.
adults. So we have young adults and adulty adults. So yeah, just basically working with people to help them get their heads around the fun and games that is diabetes a lot of the time. But I think just because of the work that I do, because there's so few of us out there in diabetes land. And I can remember when I first started working in adult services, because I'd previously done some diabetes work working in pediatrics, where there's quite a lot out there. There's a lot of guidance, there's a lot of research. And then I moved up into adult services and went to look for the guidance and research, and there's hardly anything there. It was really scary. So I think this is one of the things, because there's so few of us working in adult services, that we do now, because everybody is talking about mental health, and we've had some really amazing advocates with diabetes who've campaigned about mental health, who've really raised awareness. Because of that, there's so much more going on in terms of projects we can get involved in and research that's going on. So yeah, the invitations have really started coming for lots of really exciting groups and projects. So it's lovely, but I'm not very good at saying no to stuff. So I do get involved in far too much a lot of the time.
You're a very busy woman.
Yes,
I'm gonna pass you over to Flipper, and what Flipper's gonna do is go through some random quick fire 90-second. Well, they're longer than 90 seconds.
Yeah, we call it 90-second questions, Rose, but it's never lasted 90 seconds. But we've cut down the questions, so we might only be 5 minutes rather than 15.
There is hope. There is hope.
Soon we're just going to be asking people, and what's your name? And there. So I think you've already answered the first question, just chatting with Mary, which was how would you describe your work? But which parts, because you work in quite a few areas, what's the areas that you enjoy the most?
Oh, it's a good one. I think oh no, I like the adults as well. Oh, I'm having a crisis already. This isn't a good start. But I think there's something really, really lovely about the particular age bracket with a lot of the young adults that we work with. So we sort of pick them up around age 17. And a lot of the time when we start working with them, it's where they felt really burnt out, that things have been really, really hard for them. Lots and lots of their life decisions have been made around trying to keep diabetes happy. And we know that doesn't really work, but it kind of feels like lots of their choices in life get shut down because they're trying to just sort of keep diabetes happy a lot of the time. But when we work on that and we try and find ways around that, and then we get young people to a place where they're making decisions on what actually matters to them and not just keeping diabetes happy, and then you see them sort of going off and doing wonderful things and sort of going off to university and stuff like that, that's really, really rewarding. So yeah, I'd probably say that.
And I suppose it's nice knowing that you played a part in what's going to be a long life with type 1 and hopefully set them up for the future.
Yeah, absolutely. And yeah, when we do see them sort of coming back into clinic every so often, just sort of seeing that they're getting on okay and they're doing all right, and it's lovely to see them.
Yeah. Next question is, I am assuming you haven't got type 1. I've never heard you mention it. But if you don't want to mention and you have, that's fine. If you were diabetic, what would be your go-to hypo treatment?
Oh, that's a good question. I think I probably would do Haribo. I think the little bags, I love the Star Mix, with the squishy fried eggs.
Fried eggs are my favourite.
Yeah, fried eggs are good. I like the jelly babies as well. They're really good Haribo jelly babies. That's a really good one. And this is going to be a lot, imagining that you have type 1. If you had a choice and you did have diabetes, do you think you would be on pens or a pump?
I think in theory, I would go for the pump. I like the idea of closed loop systems and the sort of very exciting outcomes that they can give. I think the alarms would do my head in a little bit though at the same time.
Yeah.
So yeah, I think pump, but I'm not sure how I would cope with the alarms.
Oh no, and I get that as well, because everything has a plus and a negative side to it. And also, from the outside looking in, what do you think would be worse, feeling hypo or hyper?
I think feeling hypo is going to be the worst, because I've met plenty of young adults who are very hyper a lot of the time, and seem to be doing okay with that, even though we as healthcare professionals get very worried in those circumstances.
Or have they just got used to it? That's the thing.
Well, this is the other thing. Yeah, the number of people that I work with, when they do start sort of turning things around and the blood glucose is coming back into range, and they come around and they say, actually, I had no idea how bad I was feeling until I started feeling normal again. But yeah, I guess the hypo is the more immediate one, isn't it? It's the one that really knocks you for six very quickly.
Yeah, and it is quite funny from the inside, from this side of that question. It is very sort of 50-50 on what people prefer, or well, not prefer, dislike most, I suppose, because nobody prefers either. Very personal choice there, actually. What is one thing you like about working within the diabetes field?
I think it's the people. It's always got to be the people, hasn't it? People with diabetes that I've worked with are absolutely awesome, and I love how involved people with diabetes are in the sort of spaces when it comes to sort of advocacy and peer support and getting involved and getting feisty and calling out the doctors and stuff like that. I think that's my absolute favourite.
Honestly, I don't know what you mean, though. Us, weak, mild, quiet-mannered. And what's things that you're not so keen on within the diabetes field?
I would very much like to do away with shame and stigma. I would very much like to have one of those buttons installed, like I don't know if you remember, like the old Saturday morning TV shows where people get slimed on a regular basis.
Oh yeah,
I would love it, particularly if you had a healthcare professional who was being less than helpful with the language. If you could just automatically install one of those, that would be great. And yeah, I think the people who think that they can get people to manage their diabetes by scaring them, would put them in the sea quite quickly.
Yes. And I'm assuming you are familiar with this as you work in the field, but I don't actually know, being a psychologist. Do you love or hate the smell of insulin? Or have you smelled insulin?
I have smelled insulin. It's neither a love nor a hate for me, though. I don't know if that makes me very controversial. But no, I think it's all right for me. Yeah. No strong feelings in either direction.
Oh no, I hate the smell of it. It's like TCP. But anyway, a personal opinion there. And now here is one. If you were on a desert island, what 3 things would you take with you?
Oh, okay. I would take a cat. I would take. You need some sort
for
of
company, because you're scared
I'm
of
assuming
mice.
I'm not allowed to bring people with me, but
No,
yeah, a
people
cat will
will
do.
just be that step too far. We're pretty lenient.
I would take the collected Moomins books, and what would my third thing be? An everlasting supply of halloumi.
ooh,
That's quite good. Yeah, no, I'm liking that.
plain or flavoured?
Yeah. Well, thank you for that. We're now, Mary, do you want to start off on the next little section?
Sure, thanks. Yeah, right. So we're just going to talk a little bit about a little bit more about like Diabetes Connection and your background. We'll start off with like why diabetes, Rose? What made you specialize in diabetes?
Yeah, so it's a bit of a weird one, really, because I ended up where I am kind of by accident, but I'm so glad that I do work in diabetes. So so for people that don't know, that for clinical psychologists, when we train, so you have to do an undergrad degree in psychology, and then people tend to go off and they might do some sort of postgrad, like a master's or a PhD, or they can do what I did and they go and work as therapists for a couple of years, and then you can go and apply for the doctorate in clinical psychology in the UK. And that is a 3-year course where you do a combination of doctoral level assignments, and you've got to do like a big thesis and a research project and stuff like that.
Yeah.
But then you're also doing placements in different areas of mental health. So we all did sort of placements in adult mental health and CAMS and intellectual disabilities and older adults. And then in the 3rd year, you get to choose a specialist placement. So I chose pediatrics, and as part of that placement, did a lot of work with kids and families with diabetes, and I really enjoyed it. And then I sort of knew that I wanted to stay in health psychology after I qualified, but I wasn't sure where, and there were no sort of diabetes jobs around when I'd qualified. So I went off and worked in chronic pain services for a couple of years, but then came back because there was this really weird job, which was this team that was tasked with reducing unscheduled care. So unscheduled care is sort of people unexpectedly going to A&E or needing to be admitted into hospitals. And as part of that, they'd done this audit into who uses unscheduled care. So who are the groups that get admitted into hospital.
Yeah.
And one of the groups that had been identified was teenagers with type 1.
Wow.
And it just so happened that the young adult service in Wrexham, which is a really, really good service, so long before I got there, they were like gold standard, amazing. They had been asking for a psychologist for a really long time. And so it was just really good luck that I happened to have showed up when they were asking for a psychologist, and so I got lent to them for 2 years. So yeah, we did this big pilot project to see if having a psychologist could reduce unscheduled care in this group, and so I was doing individual therapy with people, but we also started doing these integrated young adult clinics where I was sitting in the room with Dr. Stanaway, who's the consultant, and the very lovely Cheryl, who's our diabetes nurse. So we developed this really holistic clinic model where we were basically looking at everything for people and not just things like their HbA1c numbers. And it so happened that, yeah, we did manage to really reduce DKA rates, and we worked out that the money that we saved was exactly my salary, which was really handy when we were making the case for a permanent service. But yeah, so we had to do there was a lot of campaigning to get that service permanently funded, but we did it, and now it's developed from a tiny little temporary part-time post to a full-time permanent role, and now I've got a little team as well, so there's 3 of us. So yeah, it's a really lovely area to work in.
And do you know, is the level of support in Wrexham, is that similar now? I'm going to say nowadays, like like post COVID and all that, like in other clinics, like in other, are you guys special because you did that work?
Yeah, I think we're still ahead of the game in terms of the amount of psychology that we have. So we're one of the services that gets used as a template by other services. A lot of services are they've pushed really hard to sort of get similar levels, and a lot of services in England are now sort of coming up to this level because there was something called NHS England transformation money. So services were allowed to bid for money, and a lot of them chose to do young adult psychology. So I think although we were one of the pioneers for getting diabetes psychology in, it does seem to be that more services are starting to do that now, and services are recognizing the importance of that integrated model of care where you put your diabetes psychologist in the diabetes team, It makes a really big difference. It means that every young adult gets a bit of psychology. It's not just the ones who are able to sort of come forwards and say, I really need this support, because we know young people can be really timid and really worried about sort of talking about mental health. So we need to make it easy for them. They need to feel like it's a really normal part of their service.
Exactly. You sat in on a normal clinic. Is that right?
Yeah.
Like in the rooms, and
Yeah.
and would you, like, did you just slip into conversation every now and again, or I'm just really interested in how you molded it in the conversation.
Well, yeah, to begin with, I think there was a lot of introducing me and sort of trying to prove that psychologists didn't have three heads. But now it's just really normal. So the minute our young people sort of come up through their transition clinics, this is Steve, he's the doctor, this is Cheryl, she's the nurse, this is Rose, she's the psychologist. So I've got my own little job in clinic as well. So we give all of our young people screening measures to do. So while their HbA1c is being processed, we give them screening measures to do about their mental health. So there's a little questionnaire that they do, and so we talk about what those outcomes have been, because it will tell us if someone's really stressing and what they're finding particularly worrying. But a lot of the time it is just sort of sitting in the background and saying, look, if things ever get wobbly, you know where we are, please come and see us quickly, don't let it become a crisis. And yeah, it's something that a lot of our young adults do take up, and they do use us, and it really helps. We hope to sort of keep them ticking over and to give them that bit of protection during that time of life where everything feels like it's changing so much and everything can feel a bit scary and overwhelming sometimes.
I think that's really important, because I know it's a thing I've raised a few times in different settings, is that when you're diagnosed, I was diagnosed as an adult, you get sort of told, oh, you've got to go to eye screening because it's really important because of this, that and the other, and you may have problems, but don't worry, and feet and all these things. But nobody mentions to you the psychological impact of having a long-term condition. And I would say a majority of people go through some sort of, when you're first diagnosed, because it is a bit of, you're just hit in the face with something, and you find to start with, and then it actually hits you that this is forever and life's changed a bit. And it really amazes me that isn't actually highlighted, that at some point you might not feel that great about this, or you might feel like that, and to come talk to us, that's not a problem, and make it a normal thing. I just don't see why it's not seen as one of the, when I say major complications, but do you know what I mean? Something that is mentioned to look out for.
I think it is.
It's not. It's sort of like, oh, well, you might, if you have anything wrong with your feet, come here. If you get this, that, and the other, your eyes, come and do this. And nobody mentions the psychological side. And I'd say that's probably what's going to hit you first.
Yeah, no, I think you're absolutely right. And if you look at the prevalence rates of issues like diabetes distress, so diabetes distress is basically a fancy way of saying how much do you hate your diabetes. And if you cross over a certain threshold with that, you hate it a lot. And we know that links onto things like much higher HbA1c, and it can be linked with other issues like depression as well. But diabetes distress, in whatever population you look at, tend to see in about 40% of people at any given time. If you imagine there was a complication that was in 40% of the people, we'd have huge services. But I think this is one of the problems, that because there's been so few diabetes psychologists, and because for a long time mental health was really stigmatized, and the sort of approach that a lot of diabetologists took was this sort of don't ask, don't tell approach, where because they didn't feel confident in talking about these issues, they wouldn't ask, and they might actively shut people down when they were talking about this stuff. Because people weren't asking the questions, these conversations weren't happening, and because the conversations weren't happening, the level of need that was out there hasn't really been recognized. It's only been quite recently where there's been big studies like the Dawn study, for example, happened about 10 years ago now. And things like the Diabetes UK Too Often Missing big questionnaire that they did.
Mm-hmm.
It's only when people have gone out and actively asked about this stuff that I think we've started realising how prevalent it is.
And in Wrexham, does the adult service also have psychology included within their general clinics?
Unfortunately not. No, there just isn't. It's only me in Wrexham. So although we've got 3 in our health board covers the whole of North Wales. That's quite a big patch to cover. So the adults, unfortunately, they would need to get referred, and then I would see them for individual therapy. And sometimes we look at offering groups for people as well. But yeah, unfortunately, at the moment, we just don't have the staff to do integrated clinics for the adults too.
Yes, and now I have the next question, but not to do that. When does an adult become an old adult?
I think that's a state of mind.
No, it's just amusing me. It's just adults turn into old adults.
It is really interesting though, working with the adults, how much of the sort of historical side comes into it, because if you're working with someone who's, say, for example, 50, and they got diagnosed at an early age, so they got diagnosed in the mid-70s, the changes that they have seen in the technology and the approaches that staff took, and what the language was like, and the way that staff felt it was okay to speak to people, that experience is so completely different from the young adults that we're working with, who may have been on tech from the very, very beginning. It's just such a dramatic shift. And yeah, unfortunately, with the adults, because I think there's often this perception that if you've lived with diabetes for long enough, that you must be fine with it, you must have made your peace with it. But for a lot of people, unfortunately, they've just learned to just shut down bits of themselves sometimes, because there's just so much that's happened. So yeah, a lot of the work that I do with adults and with the younger adults too, often unfortunately does involve a lot of work around trauma, where people have had some really difficult experiences, sometimes because of diabetes. They might have had a really scary DKA at diagnosis, or a really nasty hypo, these sorts of things. But unfortunately, sometimes as well, it's to do with how people have been historically treated in services. And although I'm sure staff have tried to do their best, often staff doing their best has caused a lot of damage for people.
I think that's it. We walk into an appointment with all the baggage we've collected over the way. And I think that's, I was talking to some healthcare professionals, and I sort of said that actually somebody new in that I deal with in my team, actually they have to prove themselves before I'll be totally open.
Yeah.
Because you're protecting yourself. And all of us, I would say, will have 1 or 2 conversations that have happened within the time we've had diabetes that have really affected us, and we can quote them word for word and know how it feels, and repeating them, you feel them. But for the person who's on the other side of that, some of them may have been nasty pieces of work, but others may have just been having a bad day at work, or thought that they were doing the right thing. But I swear they don't know the impact that they had, and to them it was just another day.
And if you're not
asking, to us, it's what we live with.
If you're not asking, if you're not comfortable in asking questions or saying about things that you're finding difficult, or they've been suppressed in your historical past with diabetes, you don't even see it, and you almost need you do need them to ask those questions of you to pull it out. And if that environment isn't there, it doesn't get asked. And so then you like, people need to reach into adults, I'm thinking, more than.
You're absolutely right. And I think I think although people working in diabetes still sort of realize this to some extent. I think it bears repeating that when you're working with a long-term condition like diabetes, and particularly type 1, where you might have someone who uses healthcare services from the age of 2 to the age of 98, that relationship that they have with their healthcare team is very, very different from regular medicine. It's not that you turn up for clinic, get patched up, and you're on your way and we never see you again. That relationship is something that people might be coming to see you for decades of your life, especially if you are just starting out in your career. You might be working with someone for the next 20, 30 years. And I think the relationship that as a healthcare professional that you need to form with people with diabetes is very different to what most healthcare professionals get trained for. They don't get trained for these long-lasting relationships. They get trained to do the sort of quick, polite, hello, how are you? What's the problem today? How can I help you? Goodbye. And I do personally think that we need to completely change the way that we train diabetes healthcare professionals, and to put that relationship centrally into everything that they do, especially as tech is playing a bigger and bigger role, because there's far less time within the consultation that's being taken up looking at blood glucose readings or messing about with insulin, because the algorithm's now going to be doing it for people. Although, of course, we know it's not 100%, but that is going to be the direction of travel. So we've got to work out what we're going to do with this clinic time. How are we going to make it meaningful? How are we going to give people a good experience and make clinic worth coming to? So I think that relationship side of things is going to become more and more important as tech starts to play a bigger role.
Yeah, and making the person more visible as opposed to the patient.
Yeah,
number.
Absolutely.
Yeah.
We were, I'm sort of noticing the time going on a bit, and Mary may disagree with me, so go backwards if you disagree.
No, keep going, because it's all this, it's kind of all in the same kind of thing, isn't it?
Yeah,
anyway.
It's really interesting, because me and Mary, when we were sort of chatting about speaking to you, and one of the things that we sort of spoke about, just because different things that are happening, different stages of life, some of the team here at DiabetesChat have had various things going on in their life, you know, like new babies, bereavement, illness, children moving on to different stages of their lives and things like that. And we were sort of talking about that having diabetes, you have all the stresses that everybody else has, but then you have this wallop added into it, the extra fun of type 1. And it's not necessarily that it's the chaos of it, but it's in the background, and it's the guilt of actually it not being a priority. It can't be a priority. And dealing with the stresses outside our lives, as well as, outside diabetes, as well as the stresses of diabetes as well. I'm just wondering, what are your sort of thoughts on the challenges of just normal life alongside?
Yeah, you're absolutely right. It's that plate that you never ever get to stop spinning, no matter how stressful life gets. And yeah, those sort of events that you talked about, the sort of getting married, having babies, kids leaving, all of these things, these are life events, and any sort of life event, any big change is really stressful for anybody, because it takes up a lot of headspace and things aren't running on autopilot like they normally might be. And we know some people really struggle with change as well, that we've got sort of different personalities too. So we know that is just really stressful, but then at the same time, you don't get to stop doing diabetes on top of it, even though there's often things that are feeling far more important, far more pressing. And I think the cruelest bit of it a lot of the time as well is that even if you do sort of try and prioritize this life change, say for example it's a new baby that you really find precious, that you want to spend time with, you obviously want to look after, but the the more you sideline diabetes, the more diabetes comes back to bite you. And so you end up in this sort of particularly vicious cycle where you really don't want to pay attention to diabetes, but the more you don't want to pay attention to it, the more it needs attention, because your bloods are looking like the scariest ride ever at Alton Towers and you're going hypo left, right and centre. So it just becomes this horrible cycle where it's just more and more stress that's going on to people. And it's very, very common that when people come and see me having been feeling burnt out for a while, it is normally because of one of those life events that's happened. Because anything that just sort of upsets your normal routine, anything that requires extra headspace, is always going to be tricky, because diabetes, unfortunately, is one of those conditions that just demands people work at 130% capacity all the time. Even with the sort of very best of tech that is fully functional, it's still really difficult. It's still really hard and still takes up an awful lot of headspace. And you don't get to stop. So yeah, I wish I had an easy answer for that. I think the best one that anybody's come up with is a desert island hotel where you just get to outsource your diabetes.
You know what?
We will set that up one day.
You know what comes to my mind, if I can just add in, is and I've seen it a few times now, Rose, is the Mel the Mammoth. Like you it just like relates to that situation so much, that the emotional impact of having all these worries in life and this busyness of life, and then the impact of diabetes as well, and then the mammoth getting bigger and bigger and bigger. That's what just like really resonated there for me.
Yeah, absolutely. And it's always at the times when you don't want that mammoth hanging around that it does show up and it does get bigger. Yeah.
And I think sometimes it's not necessarily, or this is how I see it in these times, it's not necessarily that I'd say my diabetes goes totally off the rails. It's just my standards slip slightly, or not even slip. I allow them to slip because can't deal with you sort of thing, but it's not that. But I think the thing that I notice is, whereas I think type 1 is a part of me as much as any other bit of my body. It's just there, it's me, and that's it. But I actually start resenting it because I'm not having to deal with it. That makes it sound, well, yeah, I am having to deal with it. But it is that thing that you can't stop.
Yeah.
And that sort of...
And that's the bit that I work on the most with people. It isn't that people come and do therapy and suddenly diabetes behaves all day, every day. I wish that was the case, but
you'd have a long queue.
Yeah, it's working with those bits that we can manage and the bits that are maybe a bit more optional. So I'm going to get a bit sweary, so we call it primary shit and secondary shit. So the primary shit that diabetes brings is the annoyance, the admin, the hypos, the needing to inject, all the rest of it. So that's the sort of primary stuff that diabetes brings. But then you've got the secondary stuff that it brings. So the feeling guilty, the feeling that you're not doing a good enough job, the self-criticism that comes with it, the worry about what's going on. And that's the bit that we can work with. That's the bit that's adding on extra stress, extra pressure, making life feel extra hard. And when we work on those bits, particularly the self-criticism, because type 1 is one of those conditions that is so flipping good at teaching you that you're not doing a good enough job, even though you are probably doing an amazing job the vast majority of the time. That's the thing. If you can get out of that self-criticism trap, that has a huge impact and frees up a huge amount of headspace, because when you get stuck into that fighting the diabetes, the hating it, the resenting it, that's when things start to get really tricky, and it's using up an awful lot of your energy on something that is not changing the situation. Because I know a lot of people who've really, really worked hard at hating their diabetes, and it's never made it go away, unfortunately.
And I think I always try and remember, I know what you've said it on a few lectures, but first time I heard it, it really hit me, is that we have plans for what's a normal day, good day, what we do, but to actually ahead of time have in your mind, actually, if things aren't great, what are the things that I'm going to say I'm still going to do, and what are the things I'm just going to let slide?
Yeah.
And so, like, have a bad day plan. Which bad days can be multiple bad days, not just one, but just things where, I mean, I'm using a closed loop now, and it is just, I'm just going to let my closed loop, I'm going to go high at points, but it'll come down eventually, you know, sort of thing. And just sort of give yourself permission that, you know, I'm not interfering with it. It really doesn't matter.
Yeah.
And I really like that ahead of time in your mind, you already have, okay.
Yeah.
Jettisoning that now, changing my alarms, changing whatever.
Absolutely. The other one I really like is one that I've nicked from Nerdabetic, and I use it a lot. This is trying to balance between time in range and time in happiness.
Yes.
That they are equally important, and sometimes you might prioritize one over the other, and that is okay. That they both need to have equal importance in your life.
And there's a like a presence or a in choosing time and happiness, like when you're making a decision about something and you're like, you know what, this is an important time for happiness.
Yes, absolutely. I think that
it's
is
an active thought.
Yeah. And I think that is really important, because so much of the time it can feel like diabetes is in control of your life. And so actively choosing sometimes, no, today is a time in happiness day and I'm going to do that. And that is absolutely fine to do and fine to say. And it's a very healthy way to think about things.
Are there other things, Rose, that you look at with like self-criticism? Like, are there little tools that we could be more aware of using, or is it harder than that?
Well, I think it kind of depends. I think one thing I would definitely recommend, and I'm preaching to the choir here, but getting in a group with other people with diabetes is really, really important. And if you're the parent of a young person with diabetes, try and get them in a group. They'll hate it, they'll rebel against it, but do all you can to get them in a group and keep them in a group with other young people, because I think so much of the time just understanding that this is normal, that other people go through this as well, that you're not the worst person with diabetes in the world, that other people struggle too, that this is just what humans do when they're trying to control a fundamentally uncontrollable condition.
Is it okay to coerce them? Is it okay to coerce?
Well, probably. I think when you balance the amount of good it's going to do them.
Yeah. See, I know the good because I have type 1 myself, and I will coerce, but I know it's hard for other parents who their kids just are saying, I don't want to go. I'm the only boy, or those kind of things. And you're like, okay, I'll come pick you up.
I would honestly, if it was one of my kids, I'd be using every dirty trick in the book, because I know, just sort of with the young people that I work with, the ones that really struggle are the ones that do it alone, because they're the ones that hold on to those feelings of shame, those feelings of isolation, those feelings of disconnection. So I think even if you've got to bribe them, even if you've got to pay them to go, I would just do it, because I think that is the single most powerful thing, is to feel that you're not alone in this. And that just undoes so much of that shame, that isolation, that self-criticism. So I think, yeah, if there was any tip at all, it would be get in a group with other people who get it, who understand it, and no one else is going to understand it. You could pay for 100 psychologists. It will not have the same effect as getting in a group with other people with type 1 who really understand it.
Yeah. And we were in a Zoom on Monday night, Tuesday night, for a piece of research over here. It's psychological, like it's a wellbeing tool for clinics. It's being co-created over here in Northern Ireland, and it was amazing. I was an adult on it, and Johnny was on it as well. We were in separate rooms, and he used language that wasn't language we use, but it was all about peer support and how being in a group of people, or in a group of friends that he knows that have type 1, that you're all the same. So he was talking about a clinic group. So like our clinic will take them and bring them together a couple of times a year. And he said, I'd have done it with the scouts as well, but I was the only one like treating my hypos, or I was the only one taking out my insulin and putting my carbs in and doing that. Whereas we were all doing it at the lake in Kilray, and we were all doing it together, and it was just made it so much nicer. Like, so doing the same things, but seeing everybody else do the bits they didn't like about the similar thing before. It was like, and he didn't say peer support. He said, meaning other kids like us, and he was able to talk about technology as well, and say, I know you don't really like wearing an insulin pump, but this is why it's really cool for me, because I can do my insulin in the class before I go, and I was so proud of them. But they don't even know the words, but they know the benefit.
I think there is something nice about being in the majority for once. I remember pre CGM for me, and it was the first time. It was when I was considering. That makes it sound more considering than I actually was. When I had been offered a pump and didn't want one, I actually sought out, was Googling, and there happened to be a Pumpers Drinks going on in London that week. So I went along, and there's something about, you're actually in the majority, and usually you're such a minority in any social setting. And it was like we were eating and everybody was just testing their blood. Most people were doing finger pricks at the time. So rather than being in that situation with a new group of people, as in, do I hide this under the table and people won't particularly notice? What am I going to do? It was just like everybody was doing it. It was the norm. And it is just so nice not having to explain.
Absolutely.
And you have the jokes. You have the jokes as well. Like, when did you change your Lancet last?
Have you got a lifetime supply in one box?
Absolutely. And you see it in the little kids as well. I remember that JDRF event in London it was earlier this year, wasn't it? There was this really little girl, so she must have been about 4 years old, and she'd only been diagnosed for a few weeks. And she was just running up to everybody with a Dexcom, everyone with an Omnipod, going, I've got one too. She was just so excited and absolutely thrilled to be around people that understood it, and to be in a little tribe of people. So it makes a huge difference.
And saying like peer support is really helpful. I mean, I believe it is, and I'm involved in it. So obviously I'm sort of pro that. But at what point do you think is the point when somebody should think about asking for help elsewhere or mentioning it? At what point does it tip over from actually peer support isn't going to solve this for you?
I think the ultimate question, because there is no sort of definitive thing, I can't say if it's however many number of days or if you feel like this bad, but I guess the ultimate question is the way that you're feeling really getting in the way of what's important to you? So is it getting in the way of you being able to live the life that you want? Is it getting in the way of you being able to look after your diabetes? Because I think it's important to sort of point out as well that a lot of the work I do isn't just about sort of people who are very, very upset. Sometimes it goes almost beyond that. A lot of people get to this burnout phase where things go very numb almost, and it feels, a lot of people say things like, I just feel completely disconnected from it. I just do not feel motivated at all. So I think if it's at a point where it is worrying you how it feels and it's getting in the way of your life, then that would be a time to ask for help. And what I would always encourage people to do is to try and ask for help early, because from a psychologist's perspective, it is much easier for me to do a little bit of tinkering to get people back on track than it is to undo a complete crisis where everything's fallen apart. And also bearing in mind that unfortunately a lot of services have pretty significant waiting lists. So even if you do go and ask for help straight away, it might well be that you have got a pretty significant wait of months, or in some services even longer than that. So yeah, I would be asking for help as early as possible.
And I think it's also important to carry on asking. I know one time when I knew I was starting to burn out, I sort of knew it. And I mentioned it, saying, oh, I need that. And I remember one of the healthcare professionals just turning to me and saying, oh, you worry too much. And then I didn't ask for a while.
Yeah.
And then I did. And it was a different healthcare professional. And they said, oh, okay, we've got somebody we can, maybe talk to somebody in this, that and the other. And I did need that help. But it sort of made me realise that actually I shouldn't have let them shut me down.
Yeah.
Because it made me feel that, I'm just, it's like you say, it's difficult asking for help at the best of times.
Yeah. And I think that's certainly a message for any healthcare professionals that might be listening to the chat, that it is hard to ask for help. And so if somebody does come and ask, you need to take that seriously. And you do not need to have a high HbA1c to be struggling with your diabetes. It can happen to anyone at any point, at any time of life.
That's so true, because were you going to say something, Tom? Sorry.
You can go, Mary. Go on, and then I'll say my point.
I was just going to say that, and I probably have said it a good few times, and like my A1C is okay, but I know that in clinic I have been told as well, like, you're the type of person we don't need to see.
Yeah.
And it's so frustrating, isn't it? You shouldn't focus just on the numbers. There's so much more to that person. You're a human being with like so many things going on, and this conversation, guy, is literally totally mind-blowing. It's so important, and it made me really sad talking about that there isn't sort of that huge support of psychological support for adults, and that needs to really be addressed. And we've had a few tweets coming through tonight saying that we rely heavily on peer support, and peer support is so good and so helpful, and you've all touched upon that. But we do need to sort of bring that next level of psychological support. Like Philippa said, like, you talk about your things like your feet check and your eyes, but above all that, personally, it should be your mental health and how you're feeling and all that sort of stuff. And we talked about I'm just trying to address the next tweet that's come through. We talked about all the emotional challenges in life, and on top of living with diabetes and changes and illnesses and work and everything. And someone put, that's why I look forward to bedtime. Thankfully, now I'm on looping, and it's the only time I get to not think about diabetes and my health because I'm asleep. And that just really just breaks me, that. And that's why I think it's so important to have this amazing people like you, Rose, like that service available in adults. It's so important.
Yeah, it is, and I think we do need to keep advocating for it, because I think although sort of services are getting better, it's still nowhere near where it needs to be. Absolutely nowhere near. And it's one of the things that does make me sad that so often services only get commissioned because people with diabetes have had to really fight or put in massive complaints and to really advocate for this stuff. And while that is amazing, and the people that advocated for our service, for example, are just the most incredible people, it was really sad that they had to do that themselves. And in this day and age, that shouldn't be something that has to happen. I think we are way beyond the point where it's common knowledge that mental health is equally as important as physical health. Yeah. And it's something that we really do need. But yeah, unfortunately, complaints are one of the things that do make stuff happen in the
having
NHS.
our voice,
so,
us guys.
Yeah.
Sorry guys for adding in. I just wanted to add the community's feelings into your amazing discussion tonight. And Sean's added on, maybe in the future we can say, in brackets, my time in rage is 90%, but my time in happiness is only 10%. And that's where you start these discussions and start looking at tools to support people, isn't it? It shouldn't be about that number.
No.
I think there's also, and I won't name the person because obviously they're not in this conversation, I don't think, at the minute in this discussion. But I know somebody who was diagnosed with another long-term condition. And at diagnosis, they were offered psychological help to discuss with somebody the implications of having a lifelong condition.
Wow.
And it struck them that they'd had another lifelong condition, type 1, that had an effect on every area of their life, of every moment of their day, and nobody had ever offered anything.
Yeah.
And you sort of look at that and you just think, it's madness.
It really is. It really is. And I think the real madness as well is when you think about how much diabetes management comes down to the person with diabetes, especially if we think about sort of pre-loops and all the rest of it, that it's just crazy that we'd expect people to do this on their own, and that when they struggled, the kind of phrases that would be used would be things like they're either not motivated, or my personal favorite, they've never accepted their condition. Like suddenly people get to a place of acceptance, and managing diabetes is really easy.
Oh man.
But yeah, it is absolutely mind-boggling to me that we're here in 2023 and we're still just at the very beginning of diabetes psychology for adults. And while there has been some amazing work over the years, if you look sort of back at the early stuff that Peter Fonagy did, or sort of over in the States, you've got the work that Bill Polonsky did and Laurie LaFell did, which is all really amazing stuff. It's taken such a long time to build this momentum and to get to a place where it can even be sort of considered to be starting to be part of mainstream care, let alone a full part of mainstream care. So we're still such a long way away from where we need to be.
Is there something in that we have this relationship from such an early age to such a late age in our lives that it's almost forgotten about, that because it's not a start and stop condition like other things are, and so there isn't a start and stop to the package for a person.
Yeah, it might well be. And I think it's one of those ones as well where, I don't know, I think because type 1 is maybe something that is less obvious to a lot of people. So I think unless you live with type 1 yourself, or you know someone who has type 1 quite closely, it still amazes me to this day how many people think, oh, you just take your insulin and then you're fine.
Yeah.
I don't think people realise just how intrusive this condition is. And so I think that is a part of it. Whereas when you look at other services, say for example cancer or something like that, the people think, oh goodness, if I was diagnosed with cancer, that would be life shattering, that would be awful, that would be terrible. But I think a part of it is that there just is this fundamental misunderstanding of what's involved with living with diabetes.
And I don't wish. Go on, Philippa. I keep adding in. I'm not meant to be here, but it's so fascinating.
Honestly, doesn't want to put his name down as a co-host, Rose, but no, Tom does lots. I think it reminds me of a conversation that I had with a friend who was doing a sponsored walk or sponsored something, and she says, "Yeah, it's really embarrassing because I spend my whole life saying to friends and family, no, I'm fine, don't worry. No, it's nothing, I'm fine. You don't have to worry about me. No, it's not a problem." And she says, all of a sudden, I'm going around saying, do you know this is really major, has a big effect, could have horrible consequences unless we have money for research and help. And it just made me laugh because I think, I do exactly the same. It's just like, no, don't worry about it, I'll be fine. Just let me eat this and I'll be fine. Just give me 5. And I feel guilty for saying, I just need to sit for 5 minutes and then everything will be fine. And we sort of brush over and sort of make it, we're artists at just getting on with life regardless. That actually, are we doing a disservice to ourselves? Because then people don't think it's a big deal because we just get on with it and it doesn't stop us particularly or have major effects that people see or we play down that it does. But do you know what I mean? We're our own worst enemies.
Well, absolutely. Maybe we need like a massive coordinated crying session that everyone agrees is going to be a day. We're just going to go for it. But I think you're absolutely right, because I guess a lot of the time though is thinking as well that if you didn't say I'm fine, I'm just going to carry on, like what else would you do? Because you do have to a lot of the time just compartmentalize that stuff, and because you don't get to stop, you don't get to sit and cry and go poor me, because the diabetes doesn't stop because you feel sad. So it is a difficult line to tread a lot of the time, and it isn't something that should be down to people with diabetes to communicate this level of need. It should be something that services understand. And I do think that things are definitely changing. I do think they are. I think even in the relatively short time that I've been working in services, I remember the conversation with other psychologists was, how can we get people to recognise that this is a thing? How can we get people to understand that psychology exists? And now that is changing. And looking at things like the Diabetes Psychology Network, we've got something like 150 people in that group now, whereas when we first started out, there were 12 of us on a little email list. So things are changing. Not at the rate that I would like, but they are changing.
See, I'm hearing Flipper talk about like the invisibility of it and downplaying it, and then having to upplay it like for fundraising and things like that, because it really is hard. But what you know, and you were talking, Rose, about like it not being understood properly, like to get better services in the past, just how. And what I'm thinking of as an adult with type 1 and having a child with type 1 and going through pediatric services and living in adult services and diagnosed into adult services at 18 and being treated like I had a different type, a non-type of diabetes, as opposed to having a type of diabetes. So as if it changes as soon as you go into adults, your diabetes, your type 1 becomes diabetes. And that's like it's not fair on those who have type 2. They're not getting the specialized care that they need. We're not getting the specialized care that we need, and it's different and it affects us differently. And I know we've talked a lot about type 1, and I kind of would like to to talk a little bit about type 2, if you have any experience with that in your practice too. And it's just very different, but we're called the same. And the longer we have type 1, the more we will connect with just having diabetes than necessarily type 1, and become more invisible.
Yeah. No, I think you're absolutely right there. And yeah, people with type 2 diabetes do have many of the same struggles, and that feeling of stigma is such a big thing, no matter what type of diabetes you're living with. And it's something that really eats away at people and can be so harmful. And yeah, I work with lots of people with type 2 diabetes as well, whether that's to do with it could be burnout, it could be needle phobia is a really big one. Disordered eating is a really big one as well. And I know we have things like the phrase TIDE, for example, which is short for type 1 disordered eating. But people with type 2 on insulin can just as frequently and do just as frequently have
so believe
experiences.
That.
Yeah.
Because not
the treatment
been
for now is disordered eating with type 2 though.
Sorry, say that again.
Well, you know, like they now promote going on strict, really low carb, low calorie for the first however long to try and put, stop the development or the progression of type 2.
Yeah.
In a way, it's sort of, if I had to write, not that I know that much about it, so as a lay person, if I thought somebody asked me, write a sort of, how do you get somebody to get an eating disorder?
My thoughts exactly.
Actually, what they take people who are diagnosed with type 2 actually would be quite a template for me.
No, and this is how you manage your diabetes then after. Really restrict yourself.
Yeah, it's a really tricky one, and it is something that is, I think we're only just starting to understand it, because I think when these sort of trials like the direct trial, which was the big sort of very low calorie diet and all the rest of it, when that came out, I think people were so excited by this idea of remission and that you could get rid of diabetes, all the rest of it.
Who was excited, Rose?
But the results were so small.
Yeah, and it's a really difficult one. And interestingly, I saw a presentation on this at EASD when I was there last week, that even people in the direct trial who managed to achieve remission and had these amazing results, the minute they had a life event and life got hard again and they stopped having all of this focus on their diet, and as a lot of us do, we sort of turn to food as a comfort during difficult times. Diabetes is back on again. Weight comes back, diabetes is back.
Of course.
So it's really tricky. So I mean, hats off to people that do manage to achieve remission, because that is a feat. That is a really, really difficult thing to do. But the grind of staying in that remission space is incredibly difficult. And I think it's demanding a huge amount from people. And please be clear, I'm not against remission. I think if people want to go for it, if they feel like they can, if they've got the support, then definitely do. But I think it isn't maybe the holy grail. And I think we need to be realistic about how much work it takes. It is very, very hard.
I think that's the word, realistic, because after 5 years, 8% that started on that remained in remission, and yet it's a national program. That kind of just echoes like, this is what we're aiming for, because it's so good.
And it's a progressive illness as well. So it's sort of, and I suppose the thing is, if somebody has told you at the start, if you do this, you can get in remission and you'll be fine. But it's progressive, and the likelihood is that may not work forever. But also, does it add to the sense of like failure as such when other medications come in? Because I always feel really bad that people, or some people I know who have type 2, have like almost been threatened with the need for insulin. And you're thinking, in what other progressive illness would you say to somebody, oh, you're going to progress and over time things might change? And they wouldn't actively try and promote, when you need something, then that's the right thing for you. Rather than, oh, but if you do this, you'll end up having to do that, and that's really bad. Injections,
and so you have the threat
and this,
of
that, and the other.
you're given the threat of
than,
insulin as a bad thing, and yet like to stave off having this terrible bad thing, you have to further restrict your life for as long as possible. And we talk in the type 1 community about like not low carbing, that's probably not fair. Everybody chooses how best to manage their condition themselves, but in a way that it's a choice. And then it doesn't become a choice when it's restricted like that, because that's forced on you, or else you fail.
Yeah. And I think the dangerous side of it as well is that there might be a perception at some point that if somebody with type 2 doesn't achieve remission, if they do end up on insulin, that they maybe didn't try hard enough at the weight loss. And we all know that a lot of people don't get to remission, that a lot of people really struggle. And I think anybody on this call that's sort of tried to do a restrictive diet and hasn't managed it, well, congratulations, you're a human. It's really, really hard. So I think there's a lot of struggles that people with type 2 also experience, and people with gestational as well. And I think the issue that I certainly have as a diabetes psychologist is kind of trying to work out, well, where does it stop? Because if we keep sort of going and going, we'll probably end up with a diabetes service that's 90% psychologists. Then you'll have a couple of healthcare professionals on the side, which is, of course, not realistic. We do need to get to a point where we say, okay, that there is a certain amount that we can realistically work with, and the rest will need to be sort of managed in another way. But it's difficult to work that out. And I'm certainly finding that the more I learn and understand about diabetes and the struggles that people with diabetes are going through, the more I'm just absolutely flabbergasted that this hasn't been a thing forever. Like that there wasn't a diabetes psychologist when they first developed insulin. So
and like I'm going right back to your 90 seconds and the thing that you don't like about diabetes, and you said shame and stigma, and like the whole bits of like the stigma we get from HCPs that should know better, and tell us and tell our families and tell society how things should be and how things are when they're not, and they're misunderstood, or they haven't had proper diabetes training, or whatever. But then there's our families that are around us, and the stigma we get from those, because they think we should be a certain way. It should be easy, it should be fine, and because they don't feel it in their bodies. And then there's the internal stigma that all of this then just affects us and changes our own beliefs, because you get worn down.
Absolutely. And it is really difficult when you are sort of having to put on that armor every day, because you know that someone's going to make a comment, or somebody's going to say something about the way that you are managing, and it isn't fair, and it isn't right, and it shouldn't be the role of people with diabetes to constantly have to educate society about what is helpful, what is not helpful, and what it's like to live with this. And I think it's something that is improving in some ways as we get more people talking about this stuff. I don't know if you look recently there's sort of lots of people on, was that Personal Coronation Street with type 1, and there's more representation, there's more famous people who are talking about it, which is certainly a good thing. But I think the stigma side of things and educating I think that is the next big development. I think we've got sort of tech that's coming along nicely, but I think now we need to start thinking about the person behind the tech.
Yeah, and I keep thinking about people who have type 2 and those with gestational and other types of diabetes that are getting a little bit lost in the system, because like I know our voice is strong because it comes from a historical belief that it wasn't our fault and it's not their fault either. And yet our voice is it has an internal strength that they don't have. And how do we help that without quietening our voice, because we still haven't got what we need either?
That's a really interesting question. I think a big part of it is sort of raising people up together. I think having sat in on lots of things like the Diabetes UK meetings, something that certainly gets discussed a lot is that there's a real struggle to get people with type 2 to advocate, to openly advocate, to be the person that stands up and says, I've got type 2 and this is what it's like. So I think where there are people who are willing to do that, who are willing to sort of stand up and talk, I think welcoming those people, raising those voices, understanding those shared struggles, I think is really important. And I'd also sort of want to be advocating for young people with type 2, because I think particularly we're seeing much higher rates of young people with type 2, and the level of shame and stigma that those young people feel is really painful to see. So I think if you come across younger people with type 2 who are willing to talk, then lift them up and give them that space and share that space, because I think that we all sort of struggle together in this, that there are so many shared difficulties and shared experiences. I don't think anybody wins by putting down another group of people with diabetes. So lifting up together is key.
Yeah.
Yes.
I have a question that's been messaged in, and I don't know what way you'll answer it, but if I read it out, Rose, my confidence is totally knocked following yet another severe hypo, gastro issues and hospital stay. I'm only going out to medical appointments. How do I get over this? How do I live again? Or how do I learn to live with it and accept it?
Oh, goodness. Okay. So it sounds like there's a fair number of sort of very traumatic events that have happened there. And it's our brains have got this propensity to want to keep us safe all the time, which is a good thing, but sometimes they do go a bit overboard. And it sounds like for this person, their brain really wants to keep them safe from the big scary outside world where scary and unpleasant things have happened, but that's at the cost of the person's freedom and their ability to enjoy their life. So I think one of the big things, if you know that your brain has been doing that, so number one is to try and be compassionate with yourself and to almost treat your brain like those slightly annoying, overprotective dogs that really want to look out for you, but they go a bit overboard, and that's often what traumatized brains do. So trying to recognize that, okay, this is me trying to keep me safe, which is a good thing and a lovely thing to do, but at the same time it's getting in the way of my life. And then keeping that sort of self-compassionate approach, maybe looking at breaking down those goals. So it might be that you choose to just walk to the end of the road and back and see how that goes. It might be that you just choose to to go to your local corner shop. It doesn't have to be anything big, but setting yourself those little achievable goals and trying to make sure that when you do go out, that you are making the space for it to be a pleasant experience as much as you can. So with the unseasonably warm weather that we're having at the moment, sort of doing something like going out and looking at the lovely leaves that are turning up on the trees, because I'm sure your clinic's wonderful, but going out for just doctor's appointments sounds like a really depressing thing to do. So trying to make sure when you do go out that it feels worthwhile, that you're doing something that feels soothing and something that feels enjoyable. And over time, that's how your brain will start to learn that the level of threat that it's experiencing doesn't need to be quite so high, and that going out can be a pleasurable experience. I think if you're finding that you're having experiences like nightmares or flashbacks from these events, it might be worth getting in touch with either your diabetes team or your GP to see if you could get some psychological support, because people with diabetes do experience a fair amount of trauma, and that's something that doesn't really get discussed. So when we talk about trauma, we often think of things like car crashes or war zones and that sort of thing. But a trauma is basically any event that was scary enough to make you have the thought, oh my goodness, I could die here. So a scary hypo will do that. A scary hospital admission will do that. And it might be in this case that getting some therapy for trauma, and there's lots of different therapies out there that work very effectively for trauma, that might be something that needs to happen as well.
You know, that's so helpful. Even just hearing how you break it down. I hope that's helpful for this person. I'm sure it is, like, and helpful for more people than just this person. Thank you, Rose, for that.
Yes. And I think it's quite appropriate with your book about a mammoth, and this is a different mammoth. It's a bit like, how do you eat an elephant? One spoonful at a time. And I often think that, and I often do that. It's like when you hear people, oh, my HbA1 sees this, I've done that, I can't do that, I need to change. And it's just like, you can't change everything at once.
No.
One thing, just one small thing you can do.
Absolutely.
And then do the next thing, because if you try and do it all at once, a bit like you're saying with diet and lifestyle and things, you can go all in. You can do whatever, but it's not sustainable for most people. But it is for some. And I think that's the thing with the low carb and whatever. I think if people are happy doing that, and that's what they want to do, and it fits in with their life and whatever, that's great. I'm very happy for anybody to live the life they want. But it's also knowing that that's not everybody's choice or would fit in. Because whatever we say, food is a big bit of our life, our culture, family, everything. A lot revolves around food and eating and drinking and things.
Absolutely. And I think you're absolutely right, Flipper, that it's finding what works for you and having that sort of plan of, I think I always try and get people to identify, well, what is step one? So what is your first step? If things have gotten off track, work out what step one is and get steady at step one, because so much of the time when I see people who are burnt out, it's because they have tried to do things absolutely perfectly, where their whole life is just about diabetes. And unsurprisingly, brains don't really like that, because that is often quite boring and unhappy place to be. So it's always better to be steady at something like a 6 out of 10 than it is to be 10 out of 10, 0 out of 10. So yeah, finding that first step, finding a steady place that you can be at and feeling safe at that point, and then you start thinking about the next step, is always the best way.
It's been fantastic, Rose. Thank you so much.
I've
Yeah,
really
Rose,
enjoyed
it's been
talking
phenomenal.
to you. Yeah, it's been a really, really nice session to do. Yeah, more than happy to come back if you want to talk to me again.
Rose, you'll regret saying that. But we're
She
very
said it,
pleased
guys.
you
She
said
said
it.
I'm looking at the calendar. There's a gap. Quick.
You'll be on every other week.
Group sessions, Rose. Like, what
Oh.
about those? I'm only joking, but I'm not joking.
We'll pretend it's an actual diabetes chat, but it'll obviously be Mary, me, and Tom just wanting therapy.
I can be the diabetes chat agony aunt. That would be fine.
Oh,
We'd keep you busy.
just even seeing how it works, Rose, and hearing how it works, and hearing how it works from your voice as well. It's so comforting but simple too. Like,
Yeah, and I think this is it a lot of the time. I think sometimes we, although sort of psychological therapy is something that is complex and does take a lot of skill, a lot of the stuff that we do is very basic. A lot of it is sort of when we just talk to people about how it is you're feeling, and it's amazing when you see this happening in the room, that someone will start talking about this self-criticism and all of these beliefs that they've been holding on to about themselves, and then the minute you say it out loud, this change seems to happen to people, where you realize that a lot of this sort of criticism, the stuff that you've been beating yourself up with, that maybe it doesn't actually need to be there, maybe it doesn't make that much sense. So although it's a big part of what we do is sort of complex and very skilled, a lot of what we do is very, very simple as well. A lot of it is just reminding people that you're a human and this is really flipping hard a lot of the time. So for you to feel like it's hard is okay. That is what you should be feeling sometimes.
and I think we're just so jumbled up that we think it is a complex thing because it's so jumbled up, and we can't take it apart. But if we go to ask for help, we haven't got the energy to deal with it in a complex way. But actually, the solution is, how to unjumble it in a simple way that we can take on, like, and then kind of recombobulate ourselves.
Yeah. And I think this is it, that the vast majority of people know on some level what to do for the best, because you are the expert in your own life, you are the expert in your own diabetes. So the answer is there in you a lot of the time. It's just a case of sort of recognizing that sometimes we fall into these very, very human traps, because we've all got these tricky human minds that do like to throw some rubbish at us from time to time, and that is everybody. That's not just people with diabetes. That is just part of being human, my friend. But it's recognizing that sometimes when we get stuck into that is when life can feel really tricky. And so it's about giving yourself that time, that space, recognizing that this is your brain being tricky, and that is okay. But what we're going to do now is just to sort of have a bit of a think about whether this is all completely necessary, and what we can do to just try and get back on track with things, and above all, be a bit kinder to yourself, because diabetes is one of those conditions that really does need a bit of extra kindness attached to it.
And I think one thing I sort of say to some people when I know they're having a tough time in that is actually acknowledge the things we do each and every day, just getting out of bed and getting around. And when you look at the day, even when you're having a day when you think, I just can't be bothered today, actually most people have done quite a lot. They've carb counted, they've injected, they've checked their bloods, looked at their phone, decided what to do because they're doing things, planned things out. And we do so much and we just dismiss it as though it's nothing. And the vast majority don't have that.
Yeah.
Even if it's just remembering to keep your phone charged, let's be honest.
Yeah, absolutely. For a lot of muggles, if you look at the average day for a person with type 1, for a lot of muggles, that would be one heck of a day. So yeah, the fact that you've managed to get up, and even if you've sat in your pants watching Big Brother for most of the day, that is still an achievement sometimes.
Yeah.
Yeah.
Oh no. Oh, thank you so much, Rose. It's been brilliant as ever.
Oh,
Really
thank you
appreciate
very
it.
much for having me. I've really enjoyed it.
And hopefully catch up with you again soon at some point.
Yeah, we won't keep you any longer unless you want to
Yes.
stick around and listen to how we chat. We all try and give each other a big group hug.
Well, yeah, I've got to check because I can hear small people creeping around the house that should be in bed. So I've got to go and lay the law down. But once I've done that, I might come and do some listening and lurking again.
This has been phenomenal, genuinely phenomenal. Really appreciate it, Rose. Thank you so much.
Yes.
Oh, thanks, guys.
Take care of yourself.
Take
Bye-bye.
care. Bye.
Bye.
You're following #DiabetesChat.